Okay, let's go ahead and get started. We may still have folks joining, but welcome to the CWORPH webinar series. I'm Valerie Yeager. I'm a professor at Indiana University in Indianapolis, and I will be moderating our panel today. We have two presentations: collaborations between local public health and healthcare, highlighting rural success stories, and changing structures in local public health, impacts and implications. We are presenting as the Consortium for Workforce Research in Public Health, which we refer to as CWORPH. This brings together top research teams from 6 universities conducting research in the area broadly thought of as public health workforce and systems. You can see our 6 universities here. The University of Minnesota leads this group, Columbia University, East Tennessee State University, Indiana University, Johns Hopkins University, and the University of Washington. We are the home of the HRSA and CDC-funded Public Health Workforce Research Center, the only health workforce research center that focuses specifically on the public health workforce. Today's work is part of our Year 3 projects. Other notable CWORPH achievements to date include funding from the CDC National Partners Cooperative Agreement to support recruitment and retention in local public health departments. And we have recently completed a national enumeration of the public health workforce. For today's session, we would like you to use the Zoom Q&A window to ask questions. We will hold questions until the end of the presentation, but feel free to add them in as they come up for you. Presenters may respond to some questions in the Q&A directly during the program when they've completed their respective session, if that's appropriate. And you can use chat to message the host about technical issues if you're having any. And if you'd like to use closed captioning, it is available on the webinar, and your settings in the Zoom application toolbar allow you to select that. Slides will be emailed shortly after the meeting to all attendees, and an audio and video of the webinar is being recorded. A link to our YouTube channel will be shared in that follow-up email. And you can subscribe to or our email list to receive alerts about additional webinars, and the link for that will be posted in the chat. I'd like to introduce our first 2 speakers for the collaborations between local public health and healthcare presentation. Dr. Balio is a research assistant professor in the Center for Rural Health and Research at East Tennessee State University. She is in the Department of Health Services Management and Policy, and her research focuses at the intersection of rural health, health policy, and public health. She's a member of our Consortium for Workforce Research in Public Health and is focused on public health systems and workforce research, and the East Tennessee State University Newark Rural Health Research Center, and is focused on conducting policy-relevant rural health research. We also have Dr. Stephanie Mathis, who's a research associate professor also in the Center for Rural Health and Research at East Tennessee State University. She's also affiliated with the Addiction Science Center and is in the Department of Community and Behavioral Health. Her research focuses on rural health and substance use disorders. Additionally, Dr. Mathis has experience with local, state, and regional evaluations of health initiatives. She serves as study staff for the Consortium and is focused on public health systems and workforce research, and as a core research staff for the ETSU Newark Rural Health Research Center, is focused on conducting policy-relevant rural health research. Our second presentation on changing structures in local public health will be presented by Dr. Kayla Alvis. She's a research faculty member in the Center for Rural Health and Research at East Tennessee State University and is an assistant professor in the Department of Health Services Management and Policy. She has a PhD from The Ohio State University, and her research focuses at the intersection in public health and social drivers of health. She's a member of CWORPH, the ETSU Newark Rural Health Research Center, and the Vanderbilt Consortium Leadership Education in Neurodevelopment and Related Disabilities. Welcome to our presenters and all of our guests. I will turn it over to the first presenter, Dr. Balio.
All right. Thank you, Val, and thanks to everyone for being here today. Today, I'm going to present on findings from our study around the experiences of local health departments and healthcare organizations collaborating in rural settings. This study, as Val mentioned, is one of our CWORPH studies and was funded by HRSA and CDC. Here is our full team, and the authorship team takes responsibility for the content presented here, and we have no conflicts of interest to disclose. So today we're really going to focus on these collaborations in rural areas between local health departments and healthcare delivery organizations. But before we get into the methods and the findings, I want to set the stage for what we know about rural health departments and how they differ from other local health departments. Rural local health departments, unsurprisingly, tend to be smaller but often serve larger geographic areas. They also differ in their activities, services, and finances, infrastructure, and local context. And in rural areas where there are workforce and capacity challenges in both public health and healthcare, partnerships and collaborations between these types of organizations may be particularly important, but are also shaped to reflect the need of the organizations involved and their communities, which may differ than in other settings. So we know in general that local health departments commonly report collaborating with healthcare organizations, especially hospitals after the Affordable Care Act. But there's evidence of the potential benefits and barriers of these collaborations. Most of this evidence, however, is outdated from before the COVID-19 pandemic, when the landscape may have shifted, especially around public health, and with little focus on the unique considerations for rural collaborations. So the purpose of this study was to describe collaborations between local health departments and healthcare organizations serving rural areas, including the experiences, benefits, and barriers. And for the purpose of this work, we define collaborations broadly as working towards a shared purpose or goal. A formal agreement was not required. We used a qualitative approach with two tiers of semi-structured interviews. First, with national, state, and regional organizations that support either type of entity to get a high-level understanding of these types of collaborations, followed by a more robust sample of local health departments and local healthcare organizations that serve rural areas. We prioritized variation and sampling, ultimately including local interviews from individuals across 14 states. Types of local health department participants included health department leaders, program coordinators, and public health nurses. Nearly all of our public health participants also had clinical training. Healthcare organizations included in the sample primarily represented hospitals and often critical access hospitals, as well as clinics of various types. Most of the healthcare participants in our sample were clinicians or administrators. The interviews were conducted virtually and were analyzed using a rapid coding approach. We ultimately conducted 24 interviews, 18 of which were with local organizations, including 11 local health departments and 8 healthcare organizations. So now shifting into our findings, the collaborations that were shared by participants ranged in their purpose, structure, intensity, and length. Common purposes related to conducting needs assessments of various types, emergency preparedness, infectious disease, collaborative funding efforts, and coalitions. Further, on the right-hand side of the screen are some specific examples, such as rural residency programs or rotations, behavioral health coalitions, a community paramedicine program, mobile clinics, co-located services, and shared electronic medical record access. Participants also shared that collaborations were both common and critical in rural areas, especially to overcome resource limitations and address community needs. For example, one participant said that they're not just essential, they're critical. The resources are so scarce in rural communities, so we have to cobble together the resources we have and align our end outcomes. Another participant echoed this importance and the value in combining forces, saying, "How common is it?" Meaning collaborations. It's so common we don't even think about it. It's critically important because we're all here to serve our patients and our community. No one of us knows everything, but when we work together, we know a whole lot. Next, collaboration structures ranged from formal to informal based on purpose. In addition, many participants noted that collaborations extended beyond just public health and healthcare organizations, including other entities such as K through 12 schools, faith-based organizations, nonprofits, and other governmental agencies. One participant described the informal nature of their collaborations in rural areas, saying that sometimes the policy can be a note on an ice machine at a restaurant and not a written formal policy or partnership. It might be like, we're having coffee and I agree to do this for you. Another participant shared a similar sentiment about the reciprocation, saying that in some cases, it's just a matter of picking up the phone and saying, we're working through this. Can you help? There are times where they might need a hand from us or we might need something on our end. Collaborations were driven by workforce factors and also affected the workforce. Limited staffing and capacity was one of the primary drivers for collaborations, but participants did describe both benefits and challenges related to workforce. In one case, a participant described that together we can do better things for our patients and that it opened the eyes of the staff on the healthcare system side, increasing their familiarity with what public health can do and how they can work together to increase capacity. Another participant stated that we're all the public health workforce, referring to both public health and healthcare workers, however you want to say it, drawing on the shared purpose of these types of organizations. However, additional factors that may support or especially hinder collaborations included organizational leadership, interpersonal dynamics, professional perspectives, legal concerns, and competition. For example, not having leadership buy-in could inhibit collaborations. Interpersonal relationships from both personal and professional contexts were also described, including the importance of the tight-knit nature of rural communities. Professional differences in training were also described, as well as potential legal concerns related to liability or information sharing, and potential competition for scarce workers, especially for nurses and other clinicians. One participant described the overlap between organizations in terms of staffing and experience with both types of organizations. This participant went on to say that the head of public health is on our board of trustees at the hospital. The chair of public health is our retired CNO. Another of our board members is our current CNO. And they went on to describe several other relationships. Since there's only one healthcare system and there's only one public health, you have the opportunity, but you also have the responsibility. On the other hand, one person from the public health side shared their perspective regarding differences in professional backgrounds. They shared that they are a physician, so that helps. I think I understand both public health and clinicians. As noted earlier, many of our public health participants in this study had a clinical background, and several shared this sentiment that having that background increased trust and helped to open the doors to discussions with healthcare organizations. Other factors that were described as influential for collaborations included funding, communication levels and systems such as EMR access, competition not only for staffing but also for funding or other limited resources, shared goals or priorities, and policies that may impact the value or presence of collaborations, such as the distinct healthcare and public health federal agency structures, reimbursement for clinical services, and incentives or payments to hospitals based on value-based purchasing or more traditional payment structures. This was especially relevant for critical access hospitals. One participant really described this challenge related to funding, and especially the rigidity of healthcare funding. And they stated that there are really no mechanisms of the healthcare delivery system funding public health, which I think is a true failure of our system in the US. For example, you have the poor little health department funding the healthcare delivery system partners in our county. We're the local health department paying rent. We're paying providers to do free colonoscopies. We're paying them to do mammograms and so forth. There are a lot of things that we're paying the healthcare delivery system to do, yet we're the local health department that's understaffed, under-resourced, and underfunded. And to build on that particular note on healthcare initiatives, funding, and structures, I want to highlight a few hospital-based policies that were specifically mentioned by folks in our sample. The Community Health Needs Assessment and Health Improvement Plan requirements for nonprofit hospitals after the ACA was described as something that helped to incentivize collaborations between local health departments and healthcare organizations, specifically hospitals. And the movement to value-based purchasing may also incentivize collaborations. However, one participant noted that critical access hospitals specifically are not as far into value-based purchasing, and the lack of movement in this way may hinder collaborations in rural areas and further the divide between rural and urban settings. This is particularly important as many of the collaborations that were described within the study included a critical access hospital, illustrating the importance of them in their communities, but also the challenges that they may face. So, to close out, collaborations in rural settings were seen as vital among our participants, but infrastructure and incentives to support them are lacking at all levels. There may be an opportunity to increase recognition of the unique context of rural organizations, to better align incentives or build collaborations into grants or programs, and to support both the public health and healthcare workforce in rural settings. And lastly, there seemed to be a lack of understanding on the healthcare side of what public health is and public health does in their communities. Communicating the role and value of public health has been an ongoing challenge for decades, but we generally focus on that communication to the public or policymakers. While those audiences are important, it might look different than communicating with potential partners such as healthcare organizations. Making those connections on a local level and sharing the value of public health to a larger healthcare audience may help reduce some of those barriers to collaborating with them in the future. And that's everything that I have for this study. There is our contact information, and I will pass it over to Dr. Kayla Alvis.
Thanks, Casey. Right. Hi, everyone. Thank you for being here today. My name is Kayla Alvis, and I'm with the East Tennessee State University's Center for Rural Health and Research. And today I'm going to be talking about the restructuring of local public health departments since 2020. Before getting started, I'd like to acknowledge the great project team and our funders. This work was funded through CWORPH, through awards from CDC and HRSA. The findings and views I'll share today reflect those of the authors and not necessarily those of our funders. All right, so since 2020, there has been a good amount of media coverage on local health departments, especially reports of districts dissolving, excuse me. A few stories also covered mergers, but most headlines really focused on those dissolutions. Despite the coverage, there has been little research into what is driving these structural changes or what happens afterwards. So most of the past studies have focused on regionalization, which leaves a gap in our understanding of the broader motivations and impacts of these shifts. So our study aim was to characterize the motivators, processes, and impacts of structural changes in local public health departments since 2020. For our study, we use a multifaceted qualitative design. We started by identifying structural changes in local health departments that occurred since 2020 in the US. We then conducted a media search and analysis to understand how these changes were reported and discussed. We also conducted semi-structured interviews to dig deeper into the motivations and impacts behind these shifts. So to identify examples, we use a structured Google search. We have an example of what that consisted of here. We also reached out to state contacts such as public health or hospital associations to identify any cases that we might have missed. We just want to note that while we were very systematic and thorough in our search, there may be other examples out there that perhaps were not publicized and therefore are not included here. After we identified the changes, we again completed a structured Google search to identify publicly available news media articles. So that means that we only looked at articles that were not behind a paywall. For each change, 2 team members searched for articles and extracted information about the structure pre and post change, information about the jurisdiction, the timeline and process, motivators of the change, as well as impacts with particular focus on the workforce. In addition, we conducted semi-structured interviews over Zoom with individuals involved in the changes, such as past or present employees. The interview questions focused on the same domains as the article analysis, so including the overview of the change and its impacts. So through the systematic search, we identified 18 structural changes since 2020. However, only 16 met the inclusion criteria and were documented through news coverage or participant interviews. So, for example, there were a few changes that did not have any news media coverage and did not respond to interview requests. We identified 153 articles covering 15 of the changes, and this coverage varied widely in number and content. So there were between 0 to 50 articles per change, and these ranged from brief, fact-based descriptions to long editorials. We also conducted 17 interviews across 12 of the changes. If there were multiple interviews representing the same final health department, there were 3, they were analyzed together first before we synthesized across all changes. These changes occurred across 12 states and all census regions of the US. So in general, the changes fell into one of 4 buckets. So there were dissolutions or splits, which is where an entity withdrew from an established multi-county or municipality health district. So often as a part of these shifts, there was the creation of a county level governmental department. That was a shift from our quasi-governmental structure that was in place before. Mergers or consolidations, where 2 or more counties or municipalities formally joined together. So key here was that there was some form of local public health entity present before the shift. Formations is when a county, multiple counties, or municipalities formed a health department or district. This happened only when there were no locally administered public health services prior. So for example, maybe everything came through the state. And then there were closures or transfers of authority, which were less frequent, but there were instances that we identified. I know there's a lot of text on the slide, so I apologize, but this is a table that provides the general location and description of the change. So you'll notice there is quite a lot of variation. For example, there's several instances where a town joined a multi-municipality health district, or where a county and a city merged, and also several where a county left a multi-county health district. Again, these changes occurred across all regions in the US, in rural and urban counties, and in communities with various public health needs. As you might guess, based on the diversity of the change types, there were a variety of reasons why departments were structured. So something that spanned across almost all of the cases was a desire to better serve the local community. And the change was seen as a way to achieve this goal. The COVID-19 pandemic was a precipitating event for many, but there were nuances in how and why this impacted the change, which I'll talk about in a minute. Cost effectiveness and efficiency were other reasons, as well as population growth. So I mentioned there were differences in how COVID impacted these changes. So for some of the dissolutions, disagreement over COVID policies like masking, vaccinations, and school closures were a real turning point. Places that wanted fewer restrictions wanted to separate so they could set their own regulations, which is illustrated here by the quote. But I also want to note that many of these districts reported facing internal disagreements for some time, and they felt that the dissolution may or likely would have happened at some point anyway, but COVID sped up that timeline. On the other hand, some places dealing with the pandemic highlighted some gaps in the public health system, which really catalyzed an interest in creating and bolstering local public health services. So while the pandemic might have prompted some dissolutions, it also appeared to have led to some formations or mergers. Particularly for mergers and consolidations, but also in some other cases, such as formations, improved efficiency and cost effectiveness were cited as reasons, which are illustrated by this quote from a respondent noting that improved efficiency and timeliness of response for rural populations in particular was a key driver in their decision. And finally, population growth had very mixed impacts. So sometimes a reason to create a department to meet growing needs. For example, you'll see that illustrated in the top quote here, or it was cited as a reason to dissolve. So some of the health districts had been around for 70, 75 plus years, And this bottom quote here shows that the population growth in that time meant that the counties were much bigger than they were initially when they formed the district, and perhaps that they had outgrown its usefulness. Moving into workforce impacts, I will cover these in the next few slides, but as an overview, some of these shifts resulted in high turnover and job loss for the area, while others resulted in jobs gained. Participants shared mixed success in recruiting and retaining staff. Many, if not most, of the changes were difficult for staff to navigate, but there were also positive employee outcomes. So when a new department or district formed, this, of course, brought job growth. But also dissolutions often resulted in more jobs in the area because of duplicative roles. So this participant here shared that after the dissolution of the health district, there were many more leadership positions which had been hard to come by at the previous organization. And for mergers, it really depended. Sometimes there was more funding, and this meant they had more positions open. But in other cases, particularly if the merger was challenging, there may have been high turnover. Many participants reported that they did not have issues with hiring. They were able to do so easily, even if that meant training folks with minimal experience. Rural-based local health departments reported more challenges in recruiting and retaining staff than larger urban districts, which is likely not surprising. They said that they just can't offer the same level of pay, which makes it difficult. And at least in one case, the participants shared that becoming part of the county government was beneficial because it boosted their visibility. For workforce impacts for the challenges, restructuring, regardless of the form, was often difficult for staff. Dissolutions and consolidations often came with low staff morale, anxiety, and stress about if they were going to retain their job or how it might change. And particularly those dissolutions that occurred because of COVID, people use the word divorce in multiple occasions. There were also challenges related to benefit packages. So some had to switch from a pension plan to a different retirement account, which was not easy, or PTO, or the pay was not as good as it was with the previous organization, which was a real struggle. On a positive note, many participants highlighted real benefits from the changes. So some felt their organizations had become more stable and productive with staff and leaders who were more engaged and responsive to local needs. They also described new opportunities for growth and leadership and a general sense of innovation and bringing in fresh ideas and energy. And finally, to summarize all of this, so yes, COVID played a role in some of these changes, but there was a lot of variation in both how and why this happened. Regardless of the change type, the workforce was impacted. So this may be in positive or negative ways, or sometimes it was a mixture of both. And finally, the big takeaways from this work is that we first need a more robust and systematic monitoring system for changes in local health department structures, and also that local health departments need more resources, guidance, and support, not only to make the decisions, but also to manage the transition that follows. Several of our participants said that there's no real roadmap for forming a new department or dissolving a district, and that these processes involve significant hurdles, and guidance on how to navigate them effectively might help ensure these types of changes can help strengthen rather than disrupt local public health. And that is all I have for you today.
Thank you so much, Kayla and Casey and Stephanie. I want to turn to some of our questions now, and I also have a question for Kayla related to the study on structural change. I know one of the questions in the Q&A was if you're able to share the states that were included in either of the studies. And I see that Casey responded to that question, indicating that to protect the confidentiality of qualitative participants in the interviews, they are not able to disclose the states that were included in either of these. But I do wonder, you showed us a table, Kayla, that showed the HHS regions that were represented, and there was some more information in that. Are all of these structural changes happening in states that are a decentralized public health system? Or are some of these structural changes happening in states that are also a state centralized system? Can you speak at all to overarching state structures and how that related to where you found structural change?
So I will say that I don't have that information specifically in the slide. I would need to go back through the specific states and look at their state structures to answer it. It's a good question. Um, and we saw, like we showed, lots of different types of changes. So my short answer to this is that I need to look into it more to be able to give you a solid answer on that.
Okay. I know in the state that I live in, which is Indiana, we've had a lot of structural change over the last few years. Some of these quote unquote divorces occurring. But we've also had new health departments established in areas that represent a city instead of staying aligned with a county health department. And so my state being decentralized has somewhat facilitated the ability to make some of those changes. And I was just wondering, out of curiosity, if that also does occur in states that are centralized. Seems like it wouldn't, but just making sure I understand it. So I'll watch for the full paper and maybe you guys can speak to that in your manuscript. The other question that was in the chat was asking Casey for the collaboration study for an understanding about her comment that spoke to a lack of incentives encouraging collaboration from the federal government. Casey, do you want to speak just a little bit for everybody to understand your response to that?
Yeah, sure. So, there were some barriers described by participants in terms of sort of how open different funding mechanisms were to collaborative grant submissions, or sort of encouraging specifically public health to be a collaborator. And participants felt that local health departments were often sort of left out of that discussion or specific calls to include local public health when there are more healthcare focused activities that public health may also be able to support. And then I commented a little bit on this in the chat as well. But participants also did share that there were some challenges to doing collaborative grant submissions, especially when you have a giant hospital or healthcare system, even in a rural setting, and a small local health department going in together on a grant, and just sort of the level of capacity and the level of infrastructure to support those is very different. However, the people implementing the grant sometimes is more on the healthcare side, sometimes it was described more on the public health side. But that dynamic could be a little bit challenging when you've got a big hospital and then a small health department going in together. So that was sort of one layer below that when there are collaborative grant submissions or other programming where the hospital and a local health department have to coordinate.
Thank you. I've witnessed local jurisdictions receive some opportunities for federal collaborative grants, and then their county council or their commissioners refuse to accept the funds. And so there can be also politics involved in whether collaboration can be supported or certain types of funds being welcome within a jurisdiction. The health department doesn't necessarily have the authority to decide if they're able to take those collaborative funds. So there are levels of layers of complication to some of that collaboration.
And I'll also just follow up. I saw Margaret responded again in the Q&A. Yes, I think that's another concern, not concern, but difference here is we don't want people to be super prescriptive and having to collaborate because there certainly are states that do not have local health departments consistently across the state, or the structure looks very different to Val's earlier point in centralized and decentralized states in different states across the country. So it having a prescriptive call that you have to collaborate can also be restrictive in some states, depending on what their structures look like.
I see we have a couple more comments in the chat. So Dr. Jason Orr has added a comment on the structural change study and asked if you observed non-governance structural changes such as public-private partnerships or shared joint oversight of programs or staff in your findings, Kayla.
So we were primarily looking at these governance structural changes. There was I want to say a few where, because of the shift, they did have to look to partner with other organizations, but that wasn't the primary goal of the study, was to identify those. So that wasn't a big focus, but I think anecdotally that did come up in some of the interviews. And
Thank you.
then
There's a question for both projects from Rosalind Carter asking if there are any plans to include economic analyses of the impact of collaborations or economic impact for state or county health departments merging or dissolving certain structures.
We don't have a plan to do that at this point, but I do think that could be an interesting study in the future. Um, yeah, I guess I'll stop there. We don't have a plan to do that at this moment.
And then, Kayla, there's another question for you that says that when they formed a new department, did any of your participants, when they indicated that they were better able to meet the needs of the community, did any speak about negative impacts to services or their health department, what they were able to provide when they formed a new health department?
that did not come up as much, but there were some instances where they were having challenges hiring for specific positions. So then those services were impacted. But overall, people said that they didn't really impact the services they were able to provide. But there were some challenges where they maybe, especially sanitarians, came up, where they were doing contract work and they weren't able to find someone. So that did come up to some extent.
And we have another question about the structure study. So were you able to discern any differences between a merger where one jurisdiction absorbs another versus a consolidation where two come together to form a new single unit? Are those differences articulated in what you learned from participants or in the way it was covered in the media?
To some extent, yes. So there were a few where they joined a regional health district that already was in place. Those tend there reported to be fewer challenges. There were a few mergers, and but even the mergers where there were two standalone entities that came together, those were also, they had different experiences. So I can't say that overall they went one way or the other because they each had a different experience. But there were some challenges with the ones where they did come together, where there were some difficulties with trying to create a unified culture between the two districts that had previously existed.
And our colleague Beth Resnick has asked, building on the question I asked about the state structure, um, just to confirm, and I wanted to also remind myself from what you presented at the beginning, what the time frame was that you guys reviewed for the structure study. And then was it inclusive of all locations, or to Beth's question, did you focus just on rural or just local health departments?
So make sure I answer each part of that. So we were focusing on 2020 onward.
Okay.
That was the time period. So 2020 to 2025 was when we were looking to see if these occurred. We did not just focus on rural because we were not able to identify that many that were just rural. So we needed to expand it to look at everything. Um, I will also note that, to the earlier question, it looks like we looked into this, and most states were decentralized, but there's at least one example that was not.
Okay.
So there's that answer. And then I'm sorry, did you ask one more thing too?
No, the way I
Okay.
asked it was a little bit confusing. Obviously, states aren't consolidating, so you are focused at the local health department level.
Yes.
but you're getting at all locations within states, so it wasn't limited to just rural.
Yeah.
Let's see, we had a couple more things in here. Let's just look through them. There's another question about if you were able to get a more granular data on the services provided by local health departments that may have changed based on a collaboration or the structural change. So, do they limit hours of operation or expand them? Do they start providing a type of service like sexual health services versus maybe discontinuing a certain type of service? Did you track any of that level of detail?
I can start with the collaboration study for this. There were descriptions of specific events and coalitions that were described that were enabled because of the collaboration that otherwise would not have been possible. We didn't see anything as sort of detailed and thorough as a new service line for either organization. Although we did see a collaborative effort between a local health department, a healthcare system in a local area, and EMS services going in together to establish a community paramedicine program. That one was probably the closest to or is a new, I guess, service or new activity. The others were a little bit more of expanding capacity for certain activities that were relatively narrow in scope or continuing to support existing activities.
There's a question about whether any of these are formal policy changes that influence either collaboration or structure. So the example that was provided is that Minnesota has a statute that incentivizes multi-jurisdictional community health boards, offering additional funding for arrangements that are perceived to be more efficient. And then Beth also added to that question and said, are there particular statutes that required some of these changes, whether it's restructuring or perhaps collaboration? And could we look into what those statutes look like if those types of things were what guided that change? I think either of you obviously could answer as it relates to your work.
I can actually jump in for the changing structures side of things. There were several, or at least a couple states that did have policies that were encouraging consolidation in particular. So this is something that is happening in certain places around the country, and it can look a little bit different, or it does look a little bit different in different areas. Some of them were specific to jurisdiction size and trying to make sure that sort of resources were used efficiently to support the needs of communities based on how big populations were that were being served by either county or city health departments. Um, the On the collaboration side, we did not hear any state-specific policies that were identified, but there are places where healthcare and public health are particularly tied together. There are instances where hospitals are serving as local health departments or sort of that type of entity within their communities. And that can also look a lot different than probably what most of us think about in terms of like your general local county health department sort of schema.
We do have one more comment, and then I'm going to move us to talking about the upcoming seminars. So the last comment says that there's a new paper that came out a few weeks ago, and based on the collaboration studies presentation, it seems like rural communities will have a hard time recognizing the value of public health services when most of what they see are clinical services. Did any of your respondents speak to how they think rural health departments can break out of this catch-22 and be able to demonstrate value of public health services that they aren't yet able to provide? And the title of that is An Overview of Public Health Services Among Local Health Departments in Rural versus Urban Jurisdictions, JPHMP.
Sure, thank you very much. Yeah, so rural local health departments, especially in non-Medicaid expansion states, tend to be more likely to offer clinical services than other types of health departments in larger settings. And while public health as a whole is often sort of tried to move away from direct service provision and clinical service provision, it does remain an important revenue source for rural local health departments, especially when they have smaller tax bases. So it is definitely a catch-22. It requires a lot of effort and staffing to provide those services, but it's not necessarily fully sort of something that we want rural local health departments to get out of necessarily, especially when communities need those services and they might be the only one providing them. In terms of the value of public health services, I think this is always going to be hard to measure directly. A lot of these outcomes are a little bit more distant from the actual interventions or the services that local health departments are providing. There is some work more generally about the value of public health and the economic value of public health, which is all very positive and encouraging. But especially in rural areas, there's not a lot in that space to date. And again, it is hard to do that calculation in a causal way that is drawing sort of direct influence from funding certain services or activities to the health outcomes or economic outcomes of other nature.
I can second that's very difficult. We are doing some of that work here in Indiana, looking at return on investment for some public health systems change initiatives here in our state. But it can be very difficult, and the causal chain for the outcomes can be quite long. So some of that work is possible, but we have to make a lot of inferences in order to utilize those analyses. I want to draw attention to our next webinar. Thank you to our presenters today. Thank you to the participants for so many very interesting and thought-provoking questions. Our next webinar, which is the fourth of our series, will be on February 17th at 12 p.m. Central Time or 1 p.m. Eastern Time. The presentations will be from Heather Krasna at Columbia University, Retaining Younger Public Health Staff, the Appeal of Non-Traditional Benefits. And I'll be presenting the second one, Understanding the Impact of State Governance on Recruitment Strategies in Public Health. I hope you'll join us for those. And I want to also highlight that there's another ongoing webinar that's focused on fiscal austerity that CWORPH and the Minnesota Public Health Center for Public Health Systems team is putting on and hosting. This is the next one of their webinar series is February 24th at 1 p.m. Central Time. And the link to learn more about that or register for that series is here on the slide. And then I just want to thank everyone again. If you would like to learn more, about these webinars or sign up for the fourth webinar or the fiscal austerity webinar, you can always find those on the CWORPH and Center for Public Health Systems websites. Thanks, everybody, and we'll see you on the 17th for the fourth webinar series.